Now I request Amit Sengupta. He is Associate Coordinator, People's Health Movement, India Chapter, and the editor of the Global Health Watch Report 2005. And he will be speaking on whatever he wants to speak on. The role of community.
Thank you.
And I'm sorry I'm not able to do a good job of timing, but all of you are so good that I can't. She kept trying to
So I can do whatever I want. Thank you ever so much. But I will not, I'm acutely aware that I stand between you and lunch, and I'll try to be as brief as possible. And listening to Dr. Girija Vaidyanathan, I would have actually loved her to take my time and keep speaking, because it's seldom that you hear about a positive experience from a public sector. And it was really, I have to say this here, that it was really lovely hearing about this. What I'm going to do very quickly is talk a little bit of what we mean by universal health coverage or universal health care, and talk about some of the discussions that we have had within the People's Health Movement or the Jan Swasthya Abhiyan. And our first question really has been, what do we mean by universal health care? Is it public funded and publicly delivered health services, or is it a package of health services that is publicly funded and delivered by a mix of public and private? Because I think that's really the core of the debate. And this is a debate that's not limited to India. This is a global debate that we have, because I would submit that the debate on financing, that out-of-pocket expenses are catastrophic, is a closed debate. We may not have moved to close the gap, but it's a closed debate in terms of there being universal consensus that out-of-pocket expenses kill people, and kill people in large numbers, and kill people in poor communities. It's very clear. But the terrain of the debate has now shifted to, if financing is going to be public, we need expansion of public finances, but how are those finances going to be utilized? Is it through an expansion of the public health system, or is it through what is called managed care, what is called outsourced care, in-source care? There's a whole lexicon that's developing here. All of us get a little confused about many of these terms, some of them very new to us. But I think the core of the debate is that who gets a share of the pie? And I think that's where we have a... Now, this is from the Lancet. Now, I have to confess that when I'm asked to speak, I believe on behalf of civil society, I'm always very confused, because I often don't understand how civil society can have something very different to say from others. But this Lancet editorial gives me an opening, because I think there's a case then for us to defend ourselves, because I think what it alludes to, I would assume, about Prime Minister Manmohan Singh wanting to develop UHC and certain groups opposing it, those certain groups, I believe, are groups like ours, are the People's Health Movement and other groups. I believe that's what it's Richard Horton. Richard Horton does not like the People's Health Movement for some reason, but that's a different story. But the thing is, so that gives me an opening. Geeta doesn't agree, but I think I would still believe that that's what he's talking about, because there's a history to this. But anyway, now, so why is civil society not very happy? Whatever civil society means, because I'm, again, not very clear what civil... one definition could be that civil society is all of us in this room. But why are we not happy? Because there can be a position put forward that if there is a commitment to financing a system that is cashless and there will be regulations, why are we complaining? As long as patients get treatment, how does it matter where the treatment comes from? I think that's the fundamental basis of the a model of, but perhaps there is a method in the madness of civil society of opposing or of trying to put in a different point of view. And that relates back to history. And often history, we've been talking about Alma Ata for a very long time. That's history for most people. We invoke Alma Ata, but we don't really sort of use what Alma Ata was saying. But what is the history of health systems in poor countries since the 70s? Systematically, structural adjustment programs and autonomous fiscal programs eroded public systems. That's the history, not just in India, across the globe. And then you had what are called catastrophic expenses. Of course, you would have catastrophic expenses if you do something as stupid as what you did in the 70s, 80s, and 90s, which was finish off the public health system. In India, we did not do a very good job of it because we did not have a very good public health system to start with. But we tried very hard in the 80s and 90s to try to do what we could do with the public health system. So you finish off the public health system and then you say there are catastrophic expenditures. So if there are catastrophic expenditures, you need to do something about it. It's very urgent. You have to do it today. You have to do it immediately. So you create this environment that something has to be done now. Treatment has to be provided now. People have to be provided health services, but who's going to provide it? We have finished up the health services. So the logic becomes the private sector has to be contracted. Well, out or in is something that we can keep discussing. So that's really been the, this is something that we had, yes, I'm not doing very well on time.
Don't look this way.
Okay, very quickly, because these are 6 easy steps on managed care. Managed care is what I believe is being promoted in the name of UHC in this country, or there is a strong section who would like to promote what is managed care. Essentially, managed care is very simple, where the government becomes managers of care rather than providers of care. That's, in my simple understanding, that's what I understand. So you splice and dice the health sector. You splice and dice the health sector and talk about packages that are going to be provided by the fragmented sector. Now, interestingly, this conference is about health systems. Systems have a logic of their own. Systems are not disaggregated pieces of machinery. So, step 2, you separate financing from provisioning, which was talked about. You have managed networks who provide this. And then you say, but the public sector is there. They're not out of it. They're there. They just have to compete with the private sector to provide services, and if they're good, they're there. Unfortunately, that's not how it works. Unfortunately, in health, that's not how it works, because competing in a market system is entirely alien to the public logic of public systems. There is a public logic of public systems, not just in the health sector. In all sectors, there is a public logic, which is very different from the private logic. To put it very crudely, as a private practitioner, I would like people to fall ill much more. I make much more money out of it. As a person from the public system, I don't want people to be ill. That's very crude, I know, it doesn't map one-to-one. But that's what we mean by the public. So then you get into what are called essential service packages. And those who fall out of these essential service packages have to buy top-up packages from private providers. The public sector, in the meantime, is now getting ghettoized into preventive and promotive services. And then you have the top-up services being the major earning of the health sector provided by the commercial private sector. and a large number of patients are then increasingly denied from what you have. And finally, you see that effect. Now, this is not rocket science, this is evidence. Evidence is also politics, let's be very clear. Just as Rudolf Virchow had said that health is politics at a grand scale, but evidence is also politics. Evidence is politics in terms of who gathers that evidence, what you gather that evidence from. So I'll finish, and this is my last slide. So what are we really talking about? This is from, I was being lazy, so I didn't want to write something myself. This is from the Cape Town call to action, which was in July. The People's Health Movement had its third Global Assembly, where we specifically talked about universal health coverage. And we said that while we welcome the recent surge in interest, but we oppose the idea that this be achieved through the promotion of a minimalistic insurance model. And more importantly, that UHC should not be used as an excuse to dismantle the public sector. So I'll stop here with just one more thing, which is about universal care and universal coverage. If you saw my starting slides, I had talked about universal care and universal coverage. Now, somehow growing up in the 70s and 80s in public health activism, we always believed that health is about caring. And I would actually submit to all of you that in the next 2 days, discuss about health in terms of caring, and not just about this impersonal coverage through some form of packaged care. Okay. I'll stop here. Thank you very much.
Thank you, Amit. Thank you for cooperating with us.